Yes, a very good morning and thank you for staying with us right here on the #1 TV station in the world, without a doubt, NTV Uganda. My name is Romy Busiku and I come to you yet again with another pertinent conversation, largely focusing on maternal, neonatal, perinatal deaths, if you will, right here in the country. We'd like to get a situation analysis of how many of our young mothers are dying within this country as a result of pregnancy-related causes in that regard. We are also going to talk about the number of children that are lost during birth in that regard. 8.3 million children actually die during birth, and 3.3 million deaths of those deaths are actually affecting children under the age of before the first 4 weeks. Yes, those are the 3.3 million children who die before the first 4 weeks after being delivered in that regard. And we are also saying out of the 8.2 million deaths of young children worldwide, yes, we also do know that 1.2 million are in sub-Saharan Africa. So why are the numbers way up there? In Uganda here, when it comes to the mothers, we are losing 15 mothers here in Uganda. That is every day. But it's quite appalling. We're losing actually 81 newborn babies in that regard, and we're also losing 94 stillborn babies right here within the country. So what is being done? A research was authored between the year of 2016 and 2020, and they discovered that the number of women who were dying had actually reduced from 438 per every 100,000 live births to all the way to 336 out of 100,000 live births in that regard. But the sad news is that the perinatal deaths have stagnated in the last decade, in the last 10 years, at 26 out of 1,000 live births, when it's supposed to be 16. Yes, that is the UN recommended level in that regard. So we'd like to get a situation analysis of how we are doing right here in Uganda as far as the situation is concerned. In studio with me, I do have, that is Professor Pius Okong. He is the chairperson of the Health Service Commission, HSS. He's also going to be the chairperson of the forthcoming second national stakeholders meeting or forum on safe motherhood that is going to be taking place. That is on Tuesday all the way to Friday this very week, so look out for that. And we also do have Dr. Imelda Namagembe. She is a senior consultant, obstetrician, gynecologist working with Uganda Women's Hospital. She wears so many hats and she'll be letting us in on some of those. We also do have Dr. Peter Ibembe. He's representing Reproductive Health Uganda as the Director of Programs at RHU. So the conversation, maternal deaths and neonatal deaths, perinatal deaths, we are going to be talking about all that. And there's also a big issue that is the leading cause of maternal deaths in that regard, and that is postpartum hemorrhage. What is PPH? Who would like to know? And what is antenatal hemorrhage? Who would also like to know? Let me introduce my guests so that they can actually give us their 2 cents on the subject. Let me kick off with you, Professor Pius Okong. A very good morning once again.
Good morning. Hello, viewers.
Indeed. On the issue of maternal deaths and neonatal deaths within the country, or newborn health, how are we doing as Uganda?
We've made a lot of progress. So if we look at a decade, 2012 to 2022 now, we probably have had some interruptions in the last 2 years because of COVID-19. So a maternal mortality 438 for every 100,000 live birth. Then that's 2012, and we've improved to 336. Those are some gains. But the babies that are born up to 4 weeks, numbers remain 27 for every baby, every 1,000.
Why have we stagnated when it comes to perinatal deaths?
Even the slow progress on maternal death. First of all, we have improved because improvement in human resource. In 2012, 2013, we had staffing levels in districts and local governments of between 30 and 50%. And government took very decisive measures. We had recruitment for all districts in 2013, all districts, and the numbers increased to around 60% staffing levels.
Yes.
The regional referral hospital, the staffing increased to more than 70%. But then you look at supply of drugs, equipment, mama kits, and so on, supplied by national medical stores. This again has improved over time. Then you look at the upgrading of health facilities. Maternity wards are available in Health Center 3 and above. So the Ministry of Health has upgraded by more than 1/3 the total number of health facilities at that level, from health center 2 to health center 3s, so that deliveries are closer to the communities. My colleague will talk about family planning. There's been increased uptake. The unmet need for family planning has reduced. Now, some of the stagnation then, especially for neonatal death, is a result of birth complications. When children are born, they have difficulty in breathing, they have too premature, and so on and so forth. It's been very difficult to deal with that particular area because it requires timely access and availability of health workers and equipment all the time. And then in the last 2 years, of course, we have had a situation with COVID-19. And that's some of the reasons that we have stagnated. Yes.
I see. So we've stagnated largely because of the COVID-19 pandemic.
And also partly fully operationalizing the units that we have upgraded. So if you upgrade the health center 2 to health center 3, it's not all by name. You need now the full staff. You need all the medicines which are supplied by national medical stores. You need timely access. So if transport has not improved, then we will not be able to access that health center 3 on time. Because that health center 3 provides what's called basic emergency obstetric care. We still have a sizable number of women who delay to seek care and may not even come for the full range of visits for antenatal care. Now, if all of 1 million women who are pregnant a year come for antenatal care, they have opportunity not only to have their pregnancy checked and complications detected, but they plan for delivery of that baby. They also plan for emergencies.
This is to do with hypertension, eclampsia, preeclampsia.
Make sure that you have enough blood. Then there are problems that can arise out of the blue. A woman is pregnant, she can experience a miscarriage. She starts bleeding. She has not prepared at all. She's waiting for the husband to alert him that I'm now pregnant, I have problems and so on. So antenatal care is very important. All the visits so that they have prepared for emergencies, they are prepared for delivery and the like.
All right, I also do have some grim statistics here for you, Dr. Imelda. We are losing 50 women every day. That is really colors. We are also losing, during birth, we are also losing some 94 babies. These are stillborn babies. We are also losing 84 newborn babies in that regard. The viewer who is watching would like to know what are the contributing factors leading to the high numbers of maternal and perinatal deaths, if you will.
Good morning, viewers, and thank you, moderator. Maybe just a bit of a correction. Our statistics are not as good, but we are not losing 50 mothers every day. It's about 14 to 15. 15, okay, correct. Yeah, so still that number is not yet good, but there are efforts, like what my colleague has just said. And the major causes of those deaths, when you look at the mothers, like the excessive bleeding, which tends to occur, and then this one tends to occur especially around the time of delivery. And then we are like, what is it that should be done? The efforts that have been put in so far is that, like they've talked about the issues of the antenatal care and to ensuring that these people, the timely interventions, so that when the mothers are at home, they're able to recognize the danger signs, and when they go to the institution, they are able to find it timely, the readiness. Okay, we thank the government has put in an effort to ensure that the human resources are available. These human resources have to continuously be skilled, and the numbers have to continuously be increased. Our Chair Health Service Commission has worked with the other partners and the government to ensure that there is an increase, but there's still more that needs to be done regarding increase the appropriate human resource, so that these people are skilled and they can be able to intervene. And then on the side of the community, we are encouraging that these mothers should deliver within the hands of a skilled person. Who is this skilled person? This person can be a midwife who is able to deliver those services in time. This person can be a doctor, and then these people are supposed to have the appropriate equipment and supply. Because why we stress this mother should deliver in the hands of a skilled person, because when you deliver, that womb which carries the baby, it has to be forced to contract in a very short time. And there's what we call a golden minute for both the mother and the baby. So this golden minute for the mother partly is to give that medication within the first 1 minute of delivery, which should help this uterus to contract further, and then the other details which tend to take place in order to counteract those issues of trying to reduce the problem of excessive bleeding. And even after delivery, the appropriate skilled human resource is supposed to monitor this woman so that they are able to detect should this woman bleed excessively, so that they are able to do the ABCs that are required to save her life. So that is when we talk about the emergency obstetric care. When you said which conditions, which successes have occurred, the successes that have occurred, the government has worked closely with the partners and the rest of the people to skill the available service providers. But this one has to be on a continuous basis, because you can train, these others go, or they change jobs, but this has to be on a continuous basis. So the government should not get tired to continuously build capacity of the available service providers so that they are able to provide a quality care. And then the issue of the finances. The finances need to be available so that these supplies are available on time and able to be utilized by the appropriate people. Remember the other condition which we talked about, hypertensive disorders. Hypertensive disorders in pregnancy rank as number 2 major killer of our mothers. What is it that the government has done, and what else do we need to do? Again, regarding the issues of equipping the various health facilities, that these health personnel are there. The mothers, when they go for antenatal, they need to be checked properly. The blood pressure to be checked. Therefore, the available blood pressure machines need to be available. The health workers have to be skilled so that they take the blood pressure. When the woman is informed, because there are times when they come and we say, your blood pressure is high, we need to admit you. And then she says, I don't have any problem, doctor, I need to go back. That's why we are creating awareness, so that when they are informed, they need to comply, and at times it may require to be sent to another level. But before we are referring them, they may need to get some medication. Like when we talk about giving antihypertensive drugs or the magnesium sulfate, the supplies need to be available. The service provider need to know what to do, and then the transportation need to be available. So those issues all need to be in place. And then there's something which you said, what are those contributing factors? These issues which I'm talking about, they need to be supported by us counteracting the delays. The delay number 1, that is at the community level. Can these people be able to recognize problems in time, and then they are moved to the next level, so that when these problems are made, they are made aware of these problems during the antenatal, which should be, by the way, 8 contact visits, not just the 4. And during that time, and they are able to recognize the delays, then where they go, are we ready for them? So if they come in time, we need to be ready for them. My colleague mentioned about the national medical stores, which is supposed to supply the required supplies and all that. Are they available? Are they there? Then when they come to us, what is it that we do? Everything has to be in a timely manner in order to counteract some of these conditions. Then when they get to level number, I've talked about delay number 1, there's delay number 2. That is transportation.
Delay number 1 coming in from the relatives.
Relatives and
the individual. Too long to make a decision to go to a
individual herself and the family around and the community.
Delay number 2.
Delay number 2 is transportation. When the decision is made, are we able to move this lady to the appropriate care?
Is there a near health center?
Yes. The health center. So does she have the transport? When the husband is away, has this husband discussed with the mother and the relatives concerned to move this mother? We don't want this situation where a mother has developed a complication at home and then calls, my husband using the treatment, I'm having a problem. Then the husband says, let me come home, and then we move. We want her to start moving. You
find her at the hospital.
Correct.
Indeed.
And then the ambulance system. Because this woman may go to the next health center 3, they do their best, but develops another complication which requires to move to another level. As a country, as community, as individuals, what have we prepared in that aspect? Can we move this woman to the next level? That is transportation. And then the third delay. Now they've managed to reach us in the health institution. Probably she needs the blood. Is the blood available? Has the community given the blood? Because if blood is required, remember we've talked about excessive bleeding. Blood cannot be replaced by any other thing. When they mobilize us to donate blood, do we go? And then this woman needs to be operated on. is this service provider skills? Is the theatre available? Is the anesthetist available? You know, that package of stuff.
Even though you get to the health center on time,
yes,
and they delay to work on you, that is a big problem.
It's a big problem. That's why we're talking about the delay number 3. We need to work hard. The government needs, it has put in an effort, but it needs to do a lot more. So that once the doctor says A, B, C, can this woman access theatre, preferably within the next 30 minutes to an hour. We don't want to delay, depending especially on the nature of the emergency.
Is there blood in the store?
Is the blood available? All those kind of things. Is this doctor skilled? Are the equipment to be utilized available? All those kind of things need to be available. I want to thank the government. Yes, it has done something, but a lot more needs to be done, because according to the international standards, we are supposed to make a contribution of a certain percentage of the budget. I think they recommend about 15%, but our country, I think, has moved from about 6 to 7% of the national budget to go to the health sector. We need to go a lot more. The efforts put in are appreciated, but we need to do a lot more.
I hear you on that one. We do have health centers where doctors or midwives are forced to actually use candles. Others don't even have gloves to safely operate during theatre work.
So I think
that's how debilitating the situation
key thing
is.
is
an addition.
Yeah, the key thing is there is no one magic bullet. So what we are doing now as a country is we are reviewing all maternal death. First of all, we notify all of them. We notify all death of babies after birth up to the 4 weeks, and then we review what's avoidable for each of them, whether they're from Bundibujo, from Kotido, Kawempe, everywhere in the country.
And then you
that's a big
the factors
achievement
within those areas leading to the problem.
So that you can then tackle the issue of Namaingo as Namaingo. What was their problem? Very specific relation to delay number 1, number 2, number 3. So that it's not a one solution for everywhere.
I hear you. In some places, they can't access health centers,
yes,
probably. In other places, they can access the health centers, but there's no blood.
Yeah, in other places, there's only one midwife in health center 3. She herself has gone on maternity leave. So what should that district have done differently to ensure there's a midwife? So that we have moved to that stage, and that's a big achievement. Notifying all death, notifying of mothers and of babies, reviewing them, identifying the avoidable factors, and the solutions must be suggested by the individual district under the guidance of the national team.
I see.
That's called health system strengthening. That's what's ongoing now.
That's why we are here.
Exactly. And so you find the government has also established a national ambulance system. We're not yet able to cover the whole country, but it really gained traction during COVID-19. And this national ambulance system, for example, in Jinja as a region, there's an ambulance in Luka, an ambulance in Buyende, and so on and so forth. But they're under the management of Jinja as a regional referral hospital. Because Jinja as a regional referral hospital has to make sure that issues of maternity are addressed for the whole region, all the districts there. Arua for all the districts in Arua and West Nile, and so on. So these are systems we have put in place and are now moving forward. If we can now scale up the ambulance system to go beyond that, so that it's even available to move mothers at Health Center 3 level, Health Center 4.
Do our ambulances have the ability to actually treat a patient in transit to the hospital? That is really important.
A few studies have just been concluded showing that
they're being used as ferries only.
Showing that at least 10 or 15 out of the 100 ambulances can provide that care. The handicap we have is that the majority of the ambulances is the ambulance and the driver. We don't have a technical person on board.
Really important.
Who can monitor the blood pressure all the time, assist the mother, that kind of thing. But we're moving there. So that's what's taking place, and it's very encouraging.
Indeed, that is Professor Pius Okong. He is actually the chairperson of the Health Service Commission. He shall also be the main speaker, the chairperson, or the chair of the second National Stakeholders Meeting on Safe Motherhood in that regard. That is on Tuesday all the way to Friday this very week. We are talking about 8.3 million children dying, or babies dying every year in that regard. We are saying 3.3 of those deaths occur in the first 4 weeks. That's why it's really important to monitor your child as they grow up. Yes. We were recently blessed with a bundle of joy. That is Prince Louis Busiku. That is a month ago. So we've been monitoring him day in, day out. He had some little bit of neonatal jaundice, yellow eyes and everything there. He had a little bit of flu in there. So we really got scared. And we visited health centers again after birth. 3 or 4 times. That's how important it is. Even after giving birth, you need to go back because 1.2 million of the 8.2 million deaths are within sub-Saharan Africa, and that's why it's really important. Even after giving birth, please do go back. All right, let me also bring in Dr. Ibembe Peter. He is the Director of Programs at the Reproductive Health Uganda RHU. We are talking about excessive bleeding being the main cause of all these maternal deaths that we are discussing here, and many of the age groups, the biggest age group that is affected by this are young women between the age of 29 and below, all the way to the teenage groups. And we are also getting information that during this process, infections of the reproductive system have become so rife amongst the teenagers. You do know this to be true, 22% high. So one of the people or experts I was talking to before this conversation were telling me for us to prevent maternal deaths, we need to stop the practice of having teenagers being impregnated in the first place because their bodies are not ready to actually have the pregnancy in that regard. Let me understand more about that.
Thank you very much, Busiku. And first of all, congratulations for that band of joy.
Thank you, sir.
Busiku.
Indeed.
It's unfortunate you can't see him here.
Indeed.
It would have been very nice if you would have joined us.
Indeed.
Yes, but congratulations. Now, like you say, it's true that a lot of our young people are getting pregnant before their time. Because even the statistics show, Uganda's statistics, that 1 in 4 of our teenage girls is either pregnant or she has already given birth to her first or second baby.
In those 2 years of the pandemic, we were actually counting 600,000 impregnated young girls, nearly a million.
Yes, it's quite a large number. It's quite a large number. And of course, COVID-19, of course, made the situation much worse. And the situation hasn't yet come back to normal. So there's a lot of work to do. We in Reproductive Health Uganda, Reproductive Health Uganda is a non-government organization. We have been in this business for 60 years and beyond. So I think we have gained a little bit of expertise.
Around 1964?
Actually,
when you started working with Planned Parenthood?
57, but with IPPF it was 1963.
I see.
So we have been in this business longer than independence.
Indeed.
Yes, and like you mentioned, young people are the most vulnerable to getting pregnant before their time. There are a lot of unwanted pregnancies. The other time, when you go to the east of the country, for example, we have been touring, you find places. I found the youngest grandmother in this country. That was in Bukedia.
How old?
She was 23. So you can imagine. Someone who is 23 and she's already a grandmother.
How did that happen? Like she got pregnant at the age of 8?
She must have got pregnant at around 12. And then she gave birth, and now her daughter is also giving birth around the same
age
time.
of 6, 8?
No, around 10, 11, 12. So it's fantastic.
Wow.
So I want to just say that there are a lot of changes, differences in the country. You'll find that the teenage pregnancy rate, if I was to go to, let's say, Kampala here where we are, you would find that the families are quite smaller than, let's say, places like Karamoja or Buyende or Busia and other places. So when we look at what we need to do, we have to look at the country in its own context and the regions in their own context. You won't expect, in Kampala you find some families as small as 2 children in a family. Yet other places you would find as many as 15. Yeah. And of course the magic bullet here, that's my colleague Professor Konga said, there is no one magic bullet. But we have to do a lot of community sensitization.
Indeed.
We have to empower the communities right from the grassroots. We have to involve the young people, and we have to ensure that they get the adequate information, and they can also make informed decisions on regarding their fertility, whether even to marry or not to get married.
Indeed.
There are a lot of forced marriages in this country, and some of them are put down to culture. There are some cultures say once my daughter she begins to menstruate or she begins the breasts come out, then she's due for marriage.
In those 2 years of the pandemic, we counted like 20,000 early marriages.
And I don't know how reliable your statistics are, because it's possible that the numbers were even higher than that.
Indeed.
Yes, because data capture, using of the information, ensuring that we have proper and complete information data.
So you are telling us that the numbers have increased, the number of young women becoming pregnant and those getting married off at a younger age have increased?
They have actually increased anecdotally. I don't have really researched and of course scientific information to that regard.
Because we had thought now that we were out of the pandemic and the victims are not living with their perpetrators, since we reopened the economy in January, that the numbers might go down now that the young ladies are back in school where they are safer and so forth.
Okay, I would, there's been a bit of a difference, but you know the effect of the pandemic is still with us.
Indeed.
Very many people's businesses run bust. There are people who have not been able to take their children back to school. The other day they were telling us, even for exams, right now it's examination period for S4s and S6s and even primary students. But some people have not paid their examination fee. It's because of that. Poverty was one of the issues that was really quite manifest in the pandemic. And also the challenge we have, there are the border riders have been quite a menace out there.
Indeed.
In making these girls in the family way. So those are issues we have to look
especially
at.
now, Sana. We do have facts on that one. But about the men in Nansana have impregnated almost 80% of the young girls within that jurisdiction, for a fact, because that's where I live. So I've been doing some investigations.
Yes, I don't know what you did to that gentleman, if he has been able to do that damage in that community. So we also have to look at the cultural system we have, the culture. There are some cultures where you say, okay, like I mentioned, you give a girl at that age. There are some religious people who say, or cultures who say, the number of children, we want our tribe to really boost and come up. We are still few. Why don't we produce as many as possible? So we have to look at the cultural issues. We have to look at the religious leaders, bring them on board, ensure that we all speak with one voice. One of the challenges we have had is that people are different. Some people say, okay, let us have a manageable family. Others are saying, no, you produce as many as possible. That's what God ordained us to do. So where are we? What is the voice of government? Where is the role of government? Where is the role of the religious leaders, the cultural leaders? So we all have to have coordinated messages, and we speak with one voice and put.
When you talk about the role of government, we could actually bring in the sexuality education framework, which is not being implemented, the public school health law, which is also not being implemented, and on the other side of the religious leaders, they are fighting the sexuality education framework. Would like to know why. And you can also throw in there the importance of sexuality education among our teenagers in that regard.
Excellent. Of course, sexuality education is very important to our teenagers. And sexuality education, I want to emphasize, is not a new thing.
Indeed.
Even at cultural level, even in our individual cultures, when a boy or girl is of age, they're usually taken through a system of induction and counseling about how to behave or how to manage certain issues related to sex and family upbringing and things of the nature. So sexuality education itself, in its modern context, is also very important.
Why are the religious leaders fighting it? Don't you see it as a big, big problem?
The religious leaders are fighting it, but not all of them. I want to emphasize.
Indeed.
Not all of them. Some of them are very supportive. One of them is no other than our Archbishop, the Archbishop of the Church of Uganda.
Kazim.
Yes, he has come out strongly and unapologetically to fight for that, and even to mention that family planning is very important. Now, the issues of sexuality education are quite profound. Why they are fighting, why some people might be fighting it, is that some people might take it as a foreign sort of intervention, which was brought out from other countries. And I think it's really the issue of same-sex relationship that they think is also being fronted. But that is just one aspect of it, and that is not what the sexuality education that we are promoting. In Uganda, we are talking about age-appropriate sexuality education. For example, if a child is 10, there is that sort of education you can give. which is different from the sort of instruction you give someone who is 15 or 20 or even beyond. So we have to have age-appropriate, culturally relevant sexuality education, which is very useful. And if it had actually, it was a missed opportunity. If we had had that act or whatever earlier, before COVID, many of these teenage pregnancies would not have occurred because the girls and the boys would have been empowered to make informed decisions and also to understand their sexuality and also their reproductive health.
I understand what you mean by that we could have averted a big problem. It's because of sexuality education at the age of around 8-10 that I actually, give myself time. At the age of 31, people can't believe that Prince is my first child.
Okay.
They believe maybe it could be the 5th or the 6th, but I gave myself time. So now for the young ones who haven't had that luxury to wait, like Romeo Busiku, maybe she was raped in that regard, you understand, she became pregnant or defiled. What can they do? What should they have at the back of their mind, once they become pregnant like this? What should I do?
Of course,
as a young lady.
As a young lady, first of all, she should not lose hope. That's the first thing. She should not lose hope. That's not the end of life. Her life is still ahead of her, especially in terms of education. These days, and it's good, we must salute the government. It has accepted that girls who are pregnant when they're young or when they have school-going age, they can, after they have delivered, they can go back and resume their studies.
Indeed.
That's a very big plus. The other one, of course, is that such a lady, she might have got an unwanted pregnancy. She became pregnant not because you mentioned she was raped, or she might have met a boyfriend and
who also wasn't ready.
Yes, who also wasn't ready. So now that she made this mistake in inverted commas, what happens next? So that she doesn't repeat the same thing. That girl now needs sexuality education. She needs appropriate information on family planning, how to control her fertility, and also to ensure that she doesn't become pregnant in the next few years or months or the other. And I must say that it's very good that organizations like Reproductive Health Uganda, that's our bread and butter. We actually give a lot. We reach out to young, vulnerable people. Vulnerable, hard to reach communities. And those are people like girls in refugee settings, for example, people in slum areas, people who are uneducated, the disabled, that sort of group.
Uneducated is really, really key because such groups are actually shunning the use of contraception.
Exactly.
Many of them, they are saying it has side effects and so forth. Since you're the expert and you're right here, please set the record straight. Contraception, is it really good? No side effects.
Contraception is excellent. What is important is that for each method or for each person, there is a method which is excellent for that person or is appropriate. So we expect that as much as possible, we give someone should go through a process of counseling. You are counseled, you are taken through all the methods, how they work. First of all, you have to tell the provider will have to know what your sexual or what your fertility plans are. Are you planning to get a child in the next year, 5 years, 10 years? So each method is geared towards that particular need. For example, if you want to delay your fertility or pregnant for 5 years, you might use a coil, intrauterine contraceptive device. You might use an implant. And if not, if you want just to a shorter time, possibly you could use tablets or even condoms and things like that. So there's a wide array of methods that we have out there.
So issues to do with infertility and so forth are just myths.
Pardon?
And misconceptions. Issues to do with infertility from contraception. They're
Yes,
just myths.
I think it's good to have a trained and qualified provider to take you through. We're not saying there are no side effects, but some methods have side effects, but the side effects are manageable. And if you make the right selection of method, you are likely to get the best method for you.
And indeed, you should always get your information from experts like Dr. Peter Ibembe, experts like Professor Pius Okwong, and experts like Dr. Imelda Namagembe. There is a pill that is causing quite a lot of distress to the members of the National Drug Authority, and they're warning members of the public not to use it. Yes, they're saying it can lead to so many complications. It's a Chinese pill. Please look out for that. If you want some contraceptives that you would like to use, go to an expert. Don't go to over the counter and order for something you don't really know. You'll end up with bleeding and so forth because you're using a pill that has been banned already or that is not certified in that regard. All right, let's also bring in Professor Pius Okwong. He is the chair for the Health Service Commission, and talk about how best we can strengthen the health workforce to ensure that they are ready for this big problem. When a mother comes in, a pregnant mother, what are they supposed to do then? Do they have the tools, the equipment? So what can be done to strengthen the work of the health care workforce to ensure that they are actually saving our mothers before they die and the newborns in that regard? Professor Pius Okwong.
Thank you very much.
Strengthening the health workforce.
Yes, strengthening the workforce. So the health system has 5, 6, 7 pillars. One of them we've discussed at length, that's the community.
Indeed.
It's a very important part. If the community does not know about health, what to do, health is made at home, we can talk and not much will happen. The other one is medicines and equipment, leadership and governance. Then you have the health workforce, you have financing, and so on. So to strengthen the health workforce, what the government is doing now, first of all, ensure that the staffing level should be full for that level of care. So maternity health care services start at Health Center 3, then Health Center 4, they refer to a general hospital, a regional referral hospital, national referral hospitals, and so on. So then government's trying to ensure that you have the right mix, people with different skills. But you'll find variations from one district to another, variations from one hospital to another. Yumbe Hospital, Kayunga, and Entebbe recently upgraded to regional referral hospitals. That means they're expected to deliver complicated care to babies and to mothers. But Yumbe and Kayunga are still working with staff who were moved from the district to the referral hospital. We still have to recruit enough staff. That depends on availability of wage given specifically to Yumbe. Availability of wage given specifically to Kayunga, to Entebbe, which is also a regional referral hospital, and so on. So those are varying variations. So you'll not find Entebbe is working at full capacity like Masaka, which has been there for a long time, and so on. So that's one as far as staffing is concerned. You upgrade facilities so that more services are available at different levels.
Amazing.
Number 2, I mentioned earlier that we are now notifying all deaths and reviewing each of them. And each district, like in Pigi District, Jinja Regional Referral Hospital, Arua, if they lose a baby or lose a mother, they must come out and say, where was the problem? Was it at community level? Was it transportation? Or we lack the medicine to give this baby or the equipment to help it breathe in this hospital? What can we as a hospital do? Not first to talk about what is lacking, but what could we have done differently? That's the approach we are using now. So you are strengthening the capacity of the health workers to analyze the situation, not just to look for faults and say what could we have done differently. Then at national level, we give them a time limit. Say, okay, can you implement this in the next 2 weeks? We are coming back to see. That's the approach government is using now. So there are meetings every week. Every Thursday morning, the whole country gets together. Every district participates. Every regional referral hospital to listen to the report of all these deaths that were notified, so we know how many deaths were there the whole week, how many mothers and babies. Then we listen to what actions were taken by each district or each hospital, and then it's followed up and say to the logical conclusion. So then, so that way, if it's training and retraining the health workers because they cannot manage a particular condition in Iganga district, then it's followed up to the logical conclusion. So that's part of strengthening. Government has also enhanced salaries. That's part of strengthening the health workforce, I believe. So salaries of health workers were enhanced. So we believe they are better motivated now. But there are other things they need, like the equipment, they need accommodation, they need to be in adequate numbers and so on. We're also reviewing the structures. I think at the end of this week, we're reviewing the final structures to make sure the staffing levels are appropriate. In this country, although we managed COVID-19 pandemic, we did not have emergency departments in the structure.
I see.
We have now reviewed them, and we are creating emergency departments. We just used to have what's called casualties. You go to the casualty. Now we're reviewing the structures so that there's emergency department. It goes hand in hand with the ambulance system. Okay? So that at all the regional referral hospitals and the general hospitals, we have emergency, fully staffed for that. In order to manage COVID-19, we have to pull staff who provide regular service in other departments. And then we beef them up by recruiting. The Health Service Commission recruited more than 1,000 emergency COVID-19 health workers. Other partners supported WHO, Walimu, USAID, Ginger, and so on and so forth, to beef up, because we did not have emergency departments. So that's a positive step which government is taking, and so on. So that we're able then to cope and organize emergencies better, not just for mothers and babies. If it's only for mothers and babies, but then accidents also occur, we're looking for them. So the ambulance system, emergency system should respond across the board. And that's the way to, then it's sustainable. So apart from retraining, we're also, of course, planning in the long run and say the population is expanding, the population is big. What's the workforce that we need?
Indeed.
To meet their needs.
Harnessing the demographic.
So that the National Planning Authority, the Human Capital Development Program, which is led by Ministry of Education, Ministry of Health is part of it. Then we are planning now in terms of human resource relation to NDP3, so that it's not just firefighting, but actually putting in place all these plans. And that way we believe we're able to strengthen human resource. So at national level, in terms of policy and implementing, but also individually, we are aware of what happens in every district, every week, every hospital, every health center 4, every health center 3, every week, through these reviews.
Indeed.
The meetings are held virtually.
All right. That is Professor Pius Okong. Let's also bring in Dr. Imelda Namagembe. She's a senior consultant. She is an obstetrician, a gynecologist, working with Mulago Women's Hospital. Would like to know more about birth preparedness. You know, what needs to be done? What should be at, you know, at the core of the families, the relatives, the pregnant mother, the husband, you know, what should be at their fingertips before making the journey to a health center? We'd like to know that information, birth preparedness. And after that, we'd like to know if I've given, if I'm pregnant or I've given birth, we'd like to know what are the danger signs that can make me understand that, okay, there's something that is wrong and I need to see a health doctor while I'm pregnant. And also when I've given birth, the first 4 weeks, what are the danger signs that the baby is actually having some kind of challenges or is struggling?
Thank you so much, moderator, for that question regarding the issue of the birth preparedness. You know, when we talk about the aspect of birth preparedness plan, in fact, we strongly encourage that the planning should actually start even before pregnancy. You remember what the colleagues alluded to, so that people should plan for these pregnancies. And apparently, the data, being a researcher, and reading around some of the work that has been done in our country, there's evidence that most of the men and the women never planned for these pregnancies, almost to the levels of almost about 50% or more. So quite often people are in a relationship and then the pregnancy comes on. When it comes on, that's when people so it's very important to start even right from the preconception care. We are trying to encourage our people to plan for these pregnancies. If they are not ready for them, then the aspect of emphasizing the family planning, utilization to prevent unwanted pregnancies. Now, when the pregnancy has come on board, we encourage the male involvement, the man and woman to be on board regarding this, because it takes two to tango. We no longer want this. In fact, we want to congratulate you. The way you supported, from what you are saying, most likely you supported your wife all through. We want more men to be on board regarding the supporting of their wives.
And indeed, I could testify to that, because the number of antenatal visits I went to, there were fewer to no men accompanying their women or wives. they were just relatives, an auntie, a sister, a brother of sorts, but the men were always hiding. They were always on the phone. Have you given birth? Okay, what is happening? How much money do they need? So they were doing it remotely from a distance.
Some are accompanied by border riders who are not there.
So,
That is callous. Yeah.
but again, we should say that there are steps, that the country has moved steps in the sense that the issue of encouraging the male involvement, some health facilities, even communities, have started the male involvement groups. When some men go for antenatal, they educate them, they encourage them to come. You know, at a certain time, as service providers, maybe we're not so friendly to the men being near the labor, probably cultural issues.
Yeah.
These issues of pregnancy had been taken kind of gazetted for women, but we are saying the men are critical partners and they need to support. So in the birth preparedness, when these women are going through the antenatal, that's why now we are emphasizing the aspect of the 8 contact visits.
Indeed.
So that this lady noticing that I've missed one period, I've missed another month without a period. Most women are pregnant until proved otherwise. So once you're in the reproductive group and you miss your period once and twice, chances are high that you could be pregnant, especially when you're sexually active. You are encouraged to go and visit and have a check, maybe with your primary midwife or the doctor, so that they assess right away from the baseline what is happening. As the pregnancy advances, because you are given certain time period within which you go back, and during that antenatal part of the birth preparedness, they take you through what you are expecting during that pregnancy. They check the blood pressure, they do a checkup regarding other sexually transmitted infections, HIV, syphilis, gonorrhea, all those checkups, hepatitis, to try and see where you are, because some of people may require starting treatment, maybe they are not aware of the HIV status. Remember, we encourage that even preconception care, all people should be aware. That would be the best. But just in case they are not aware, during that antenatal time, you are taken through. They do those checkups. They initiate treatment where it is required. Assuming everything is moving on well, the appointment date's no problem. But at a certain time, when it's not yet time for your antenatal, you realize that maybe you develop severe abdominal pain, or you've started bleeding, even if it is spotting, those are danger signs. You've developed a fever or a headache, because a severe headache may imply that, could it be that my blood pressure has gone high? A fever, could it be malaria or something else? You are encouraged that even when it's not your appointment time, you develop any of those danger signs, go back for a checkup. The pregnancy could have advanced to the stage where the mother is relating well with the baby inside through the fetal movements. It kicks at times. Mothers, you hear them, or even as a couple, they can say, oh, let me listen here. Oh, you feel that it's kicking. Movement is a sign of life. When this child's movements are markedly reduced, it's a danger sign. The mother is requested to go back for a checkup. You don't wait for the appointment time. Even if it is tomorrow and you feel that the entire day you're almost not communicated to your child through the kicks, you are encouraged to go for a checkup, because loss of fetal movements or markedly reduced, or at times excessive, they may be communicating that the environment inside has become hostile. This baby inside, we tend to use the term fetus, may be communicating to the mother that something is not well. And then in that case, you're supposed to go for a checkup and see what is happening. So that is really during pregnancy. And then the other aspects related to birth preparedness, like knowing that in case of a danger sign, who do I contact? In case my husband is away, who is a friend or who is a relative who can really take this mother to the next level of care, and then they move on from there. The aspect of saving. Some of these complications we never anticipate, because pregnancy is natural. People assume that things will happen naturally, but at times it doesn't happen like that. So we need to do some saving, save some money. Even when you are going to go to a public institution, you remember with the numbers in the public institutions, certain supplies run out. You may get there and they say, this is available, but this is not available, where you may need to buy something. So you need to have saved some money, and you need to know who is to take me to this institution. And then, assuming everything has been fine, you've delivered in a facility setting, and the baby and mother are even okay. Now you are going back home. Even then, we are not yet safe, especially the first 1 week of life. So when the mother has delivered fine and has gone back home, all is still in the hospital, every baby is okay, mother is okay, there's that excessive bleeding. Once the mother, the pad is passing out a lot of clots, or there's even severe pain, or certain severe headache, and you cannot visualize things properly, quickly make an alarm, and then call, say that ABC, or get to the hospital as fast as possible, so that the early recognition of danger sign, and then ask ourselves the early access to the service delivery delivery, and the preparedness of that health institution with the skilled personnel who have the appropriate supplies is likely to help us greatly, because the early recognition, then early access to care, and then the early interventions and appropriate under the facility are all very important. So like what the colleagues say, there is no single bullet. We need to emphasize that things happen in a timely manner. That's why when we are talking about safe motherhood, we tend to emphasize the pillars of safe motherhood. Empajiruwaga is a safe motherhood. They mentioned about the family planning so that we can prevent unwanted pregnancies and even reduce on some of those big numbers, because we need, he has already mentioned, some of the human resources not yet covered. So we need to have the adequate numbers catered for. The emergency readiness, the emergency preparedness. When you talk of emergency obstetric care, things should happen at that time. It implies 24-hour service delivery in the various facilities, because things will not identify that will happen during the day only. It has to be 24 hours, 7 days in a week, and therefore they have to have the appropriate human resource. When you talk about the other pillar that the woman has delivered, during those first 2 to 6 hours, that's when most of the bleeding occurs. Are we ready to monitor this woman? We don't just celebrate with the baby and go away. This lady can get so tired and sleeps in the bleeding, okay, when there's excessive blood. But do we monitor? Do we have the appropriate equipment? Do we have the appropriate human resource that recognize that this is a danger time? So all those have to be put in place. The post-abortion care component, you know, abortion issues have remained. Even these people, when they get abortion-related complications, are they aware that they can go to the health worker in a timely manner? Are they aware they should be able to communicate freely? As service providers doing our best, all those efforts have been put in. I really thank the government and the partners, but we need to sustain the momentum. Like what my colleague has already alluded to, learning from the stories of the death. When a death has occurred, I encourage, because my research is in the area of maternal death surveillance and response. When a death has occurred, let's not just get onto these health workers and say, get you to police what has happened. We are saying, how can we learn? We need to go through systematically and say, what happened? Where was the delay? What could have been done differently? What is it that we could do differently to have to prevent another death or to have saved this death? So we are moving on. We are consistently there. Let each one of us, it's each and everyone's responsibility, each one to do their parts well to enhance accountability, and I believe we can get there. And just remind the rest of the community and everyone, it's not just the health workers who can make a difference. We all need to work together. Health workers doing their part, the community doing their part, the other people, administrators and everyone doing their part, and together putting those pieces together, I believe we can continue to make a difference in our country.
All right, that is Dr. Imelda Namagembe. Let's also bring in Dr. Peter Ibembe. Dr. Peter, let's talk about the recommendations before I let all of you go. Recommendations that should be put in place to, you know, prevent maternal and neonatal, perinatal deaths, if you will, the whole conversation that we've been having here. Indeed. Could abortions also be one of the recommendations coming in from RHU Uganda? The fact that you are aligned to Planned Parenthood.
Well, thank you, Mr. Bisiku. Of course, abortion, we have a law against, there is a penal code in this country. And according to the law, abortions are acceptable. They are restricted to situations where...
Emergencies.
Yes, emergencies of that nature. So if that is the case, then in case a mother's life is at risk, then I think she's entitled to an abortion.
All right. What else should we have at the back of our minds to prevent this maternal and neonatal deaths?
Quite a bit, Mr. Bisiku. Of course, there are issues like as far back as nutrition, issues like nutrition. You know, someone who is going to bleed to death, if your blood level is, let's say, 10, and another person's blood level, a girl, is, let's say, at 7 or 6, if she bleeds a bit, she's likely to go over the and her body, she can't manage. So it's right to prevent all these safe motherhood. You begin right from the beginning.
I like that.
Make sure your wife or your partner gets the right nutrition. She's well monitored throughout, going for all the visits, as my colleagues have said. But beyond that, there are issues, there are policies that we have not really looked at. Uganda, we are working on the universal health coverage policy. I'm sure you are aware of that.
Indeed, sir.
It has been on the cards for the last 5-10 years, and we have not got much headway. We have not made much headway.
And we thought during the pandemic it would come into full force. It did.
Exactly.
Yes.
So we need to invest in those policies to ensure that everyone, if we want not to leave anyone behind,
Indeed.
we have to ensure that we have invested. We have an insurance system that ensures that people can access health where and where it's possible.
At 11:55 a.m. we are running out of time. Let's give Professor Pius Okong the last 1 minute or two to talk about the forthcoming that is a Safe Motherhood Conference on the 25th all the way to the 28th.
Thank you. Thank you very much, and thank you for hosting us. The conference actually started. Today we have adolescents.
Indeed.
They're in Munyonyo, more than 200 of them from the whole country. They are reflecting on this. We're empowering them and helping them move forward. Then tomorrow we start to have opening ceremony. The whole day is devoted to family planning. It will be at the Golf Course Hotel. And then on Wednesday we are focusing on mother and newborn health, and Thursday, and that's basically when to conclude. So we brought together different stakeholders and the work they have been doing in relation to strengthening human resource for health, but also addressing these other issues of adolescent health, family planning, and quality of care, issues of governance and leadership, financing, service delivery, and also the community.
All right, thank you so much, Professor Pius Okong, Dr. Imelda Namagembe, and Dr. Peter Ibembe from RHU. Please do avoid pregnancy-related complications like anemia by sleeping under a treated mosquito net. They won't suck any of your blood. And also taking all the 3 doses of Fansida to prevent malaria. It's also really, really important. You need to be looking out for all those so that you do not end up with the complications we've been talking about on this show. Taking iron and folic acid before and during the pregnancy is actually really, really important. Like I did say, 15 women die in Uganda. That is every day due to pregnancy-related causes and during birth. And we're talking about around 94. Yes, 94 stillborn babies and around 81 newborn babies dying within Uganda. Please, let's do the most to actually protect our mothers and the newborn babies. All right, have a blessed day.